Hi there, and welcome to At the Helm. In today's episode, Dr. Charles Helm sits down with Dr. Byrne, a family physician, digital pioneer, and founder of LifestyleRX, a groundbreaking online platform which helps thousands of Canadians put their type 2 diabetes into remission and improve their metabolic health through lifestyle changes. Today, Dr. Byrne will discuss his journey from developing electronic medical record software to becoming a leader in lifestyle medicine. He'll explain LifestyleRX's diabetes remission strategy, which focuses on nutrition, exercise, and sleep, and how his program offers personalized care for 5 different diabetes subtypes. Dr. Helm and Dr. Byrne will also discuss the challenges in navigating shifting healthcare landscapes, the role of new weight loss medication, and how to help set patients up for long-term healthcare success. Be sure to follow the Institute for Personalized Therapeutic Nutrition on social media and check out their many online resources like the Diabetes Remission site, the Reversing Prediabetes site, and the TCR Type 1 Diabetes Guide. And follow At the Helm wherever you get your podcasts.
Welcome to At the Helm, the health podcast where we explore food as medicine and food as treatment for chronic disease. I'm your host, Dr. Charles Helm. I'm a family doctor who has practiced for more than 32 years in Tumbler Ridge in northern British Columbia. It's a remote rural community. And I'm also a paleontologist with a PhD from Nelson Mandela University in South Africa. I'm very privileged to be hosting this podcast from the traditional land of the Treaty 8 First Nations in the foothills of the Rocky Mountains. At the Helm is sponsored by IPTN, the Institute for Personalized Therapeutic Nutrition. Now, in today's podcast, we are going to welcome Dr. Byrne. Dr. Byrne has been a family physician and a digital pioneer for the past 25 years. He trained at Yale and McGill, and he has been a pioneer in electronic medical records, EMR, in Canada. And now he is the Chief Medical Officer of LifestyleRX. And in doing so, he is realizing his dream of turning information into better health outcomes, in particular by developing a full-stack virtual care solution that is helping people with type 2 diabetes to achieve remission. We're going to hear a lot about that program today. But I should also let you know that Dr. Byrne is on the IPTN board and also sits on the board of the BC Academic Health Sciences Network. He also has his own podcast, Finding the Path, or The Path, with amazingly 27 episodes already. We'll provide you with the link to that podcast series as well. Before I get to introducing you to this fascinating guest, there's a necessary disclaimer, and that is that the information that is provided by me or by Dr. Byrne in this podcast is for educational purposes only and is not intended to replace medical advice. Listening to the podcast does not constitute a doctor-patient relationship. And for those of you who may be on prescription medications, in particular medications for type 2 diabetes, but also other conditions as well, if you are considering making major dietary changes, there can be side effects that ensue, and in some cases, even severe side effects. So the best advice, if you're in that situation on prescription medications, is just to chat to your healthcare provider before you make such changes. And now to my discussion with Dr. Byrne. Welcome, Dr. Byrne.
Good morning, Charles. Great to be here.
Good morning. And may I call you Brendan?
Absolutely.
Thank you. So, Brendan, I would just like to know, I'm fascinated by this sort of the twin track of your career, the pioneer in the EMR combined with the family physician element, and bringing these two together to develop something really special. But in addition to that, you're on the board of the IPTN and another board, which, I mean, the IPTN is a non-profit organization with volunteer board members. That tells me that there's a lot more to you than just that twin track. So why have you chosen to be on the board of IPTN?
Well, so Sean McKelvey, who's the CEO of IPTN, I've known him for quite a while, and he was definitely one of the major influencers that changed my way of thinking around metabolism and the importance of metabolic health. and really kind of, ignited a passion within me for, addressing metabolic health, with our patients. Um, every 3 minutes, there's a new diagnosis of type 2 diabetes in the country, and we're facing an epidemic. When I look at kind of my life, when I was born in the 60s, the prevalence of type 2 diabetes was under 2%. When I went to medical school in the late 80s, the prevalence of type 2 diabetes is under 4%. Now it's somewhere between 11 and 15%, depending how you measure it. And so we've got this epidemic happening. Our genes haven't changed in that time frame, but our environment and our food certainly has changed. And so when Sean started to talk about kind of the role of nutrition in metabolic health, and then I started to think about what is it that as a family doctor I see every day. It's the manifestations of metabolic health. And so it's not just type 2 diabetes, it's, hypertension, it's heart disease, it's autoimmune disease. And so when you look kind of across the board in terms of what gets affected by your metabolism, it's everything. And so that was kind of I think the spark for me in many ways. So when Sean asked me to be on the board, it was actually a way to return the favor, because he had lit the spark for me.
Right. No, that's very inspiring. And what I'd like to just do is get straight to LifestyleRX and learn what it's about. And I see you've described it as a full stack. That's an unfamiliar term to me. Could you just explain exactly what that means first?
Well, yeah, so it's a little bit of a techie term, but it kind of means that we've built everything into a single platform to allow a program that will be comprehensive enough to make change. And so, again, more words. Let me describe it more simply. What we know for those of us who practice lifestyle medicine, we know it works. And lifestyle medicine is essentially helping people understand the power of their lifestyle behavior choices. And so what you eat, how you move, what you do for activity, your sleep, your stress response, your relationships, and your sense of purpose. These are the pillars of lifestyle behaviors. And when we look at kind of where health comes from, it's this interaction of your lifestyle behaviors in your environment with your genetics, right? And so what we see is we can't change the genetics. The environment is hard to change, but it has some components that we can change. But what's available to us are these behaviors, and we can definitely change these behaviors. And so with lifestyle medicine, what we do is we work with people to help them understand the impact of those behaviors on their health, and not just in terms of their blood tests, but also in terms of how they feel, in terms of, kind of their weight on their scale, other kind of factors. So we help them understand that. The challenge, though, for a doctor practicing lifestyle medicine is not that it's effective. It's very effective. It's just very time consuming, because there's a lot of explanation necessary to understand, the impact of just something as simple as fiber in your food. What does that do? And so I became passionate about lifestyle medicine. I opened a lifestyle medicine clinic back in 2017 in White Rock. If you walked into the clinic, there's like plant-based cafe. The whole space was a gym. There's a meditation space in the back. The whole idea was to put the behaviors kind of front and center into the experience of being in the clinic. And it worked, right? And people came in and they learned and they had this experience, and they made these changes, and it was quite wonderful, except for the fact that from, as a physician and, trying to, pay for it all, it didn't work, right? Because it was so time consuming that, I think at one point my wife kind of looked in at me. She's like, you just got paid $30 and you were in the exam room with that person for 50 minutes. There's no, she kind of laughed. There's no other physician on the planet that would do that, right? Like, it just doesn't make sense, right? And so the economics of lifestyle medicine have never made sense because it takes too long to explain. And so when COVID hit, we suddenly had this beautiful space that nobody could come into. We jumped on Zoom like this, and we were doing things remotely. And the penny dropped for me, which was, wait a second, we can do one-on-one with Zoom very efficiently. So we can have a one-on-one encounter like you and I are talking. We can actually do groups on Zoom, and we can have people from all over the province come in at the exact same time. And it's easier for them than driving to my clinic. And if we build in an asynchronous component, a curriculum where patients can look at videos and can have exercises to do and can have downloads that they can print and put on the fridge, we can take an hour of physician time, and we can take that and we can multiply it out to 30 or 40 hours of program time. And now all of a sudden it works because I'm not explaining insulin resistance to every patient. They've watched a video on it. They've watched many videos on it. So we can take some of the explanation away, and we can do a better job in terms of educating. And so the big insight with LifestyleRX is if we built it all, the electronic medical record, the virtual tools to communicate, the videos, the curriculum, if we built all of that into our tool set, we could even go further than what we were doing in the clinic, because all of a sudden now the doctor can focus 100% on the patient. They don't have to worry about like, okay, now I've got to, tell them, about, the role of protein and satiation. There's videos for that. You can pace it out. You can use educational strategies to help people understand. And now as the physician, you can start to be focused on this person in front of you. What's the single most important thing that they can do right now at this moment that will have an impact? And you can guide them. And so, we find ourselves at LifestyleRX, the physicians and dietitians and counselors that are on our team, we're Sherpas, right? Like we can't climb the mountain for people, but boy, we have some pretty good paths up the mountain. And so our goal is to help people find the path. And that's why the podcast is Finding the Path. And the path, simply put, is where your behaviors align with your physiology and your health improves. And
And I guess everyone, the P in IPTN stands for personalized, and I guess everyone has got their own path. So that's where personalized treatment comes in. They've got to find the path.
And it's interesting you say that, because when we do the Zoom sessions, you get the Zoom checkerboard, and there's we'll have 30 people in a session, and so you realize two things in the first session. One, I'm not alone. You look around the screen, and it's like, oh my goodness, there are so many people that are dealing with the same thing that I'm dealing with. I'm not alone in this. Then you look around and you see, but everybody, there's different ages, there's different genders, there's different ethnicities. There's just differences here. And you realize I'm not alone, but I've got to find my own path because I'm unique. And we are unique, right? We all have strengths and weaknesses in our lifestyle behaviors. We're all very unique in terms of our genetics, and our environments are different, right? And so it makes no sense to have a one size fits all, because our lives are not the same, right? And that's kind of, I think, as a practitioner, what is so fun about practicing this way is you actually start to really try to think, you've got some perspective and you understand the strategy well, but it's like, okay, for this person in front of me, what's the one piece? If we could change one piece, what would that one piece be? And that's often where you try to align their focus onto one thing.
Right. And it sounds like, COVID, for all its tragic outcomes, there were silver linings to the COVID cloud, if I can put it that way. And this seems to be one of them. If it hadn't been for COVID, maybe you wouldn't have taken this route. But if I can ask you, putting, from a personal perspective, let's just say I'm a really busy family doc. I totally believe in the virtues of lifestyle medicine, but I'm just challenged to find the time with my patients. I know how much time it's going to take. So if I refer my patients to LifestyleRX, or can they self-refer? That's another question. But if I refer them, can I just trust you to get the job done, and they're going to come back to me after 12 weeks or whatever, fully educated? Is that how it works? Or?
Yeah. So So you can refer directly, or we have these little pads with a QR code where you can give somebody this little prescription pad. We call it a lifestyle prescription, and have them check it out. They have to register themselves online and get themselves set up, and essentially they'll book a call with our intro team. If we don't have a referral, we'll reach out to the family doctor or a primary care provider to get a referral. And if the primary care provider, for whatever reason, says no, this is not appropriate, we won't see the patient. So we want to augment or provide a service to the family, because we're not doing primary care. Like I joke, we can do a lot through Zoom, but I can't examine your feet, right? I can't take a blood pressure. So, we're not replacing the primary care provider. So patients can register themselves, but we do check in back with their family, their family doctor or primary care provider, and be sure that it's okay or the right thing. The other thing that's interesting, and you touched upon it, one of the Dr. Werner Spangel, who is the second doctor at LifestyleRX, and he's been a lifestyle medicine physician for longer than I have, and he would express that the challenge of trying to do this in primary care, and often the challenge in primary care is that if you see 10 people with type 2 diabetes, maybe only one of those 10 people are ready to make the change. And so you spend, not only is it not time efficient, but you're talking to 10 people, but not knowing which one of the 10 is ready to make change. The thing that I love about kind of this lifestyle prescription concept, where the physician says, hey, do you need help with your lifestyle behaviors? Are you open to learning more? When you give that to a patient, they have to take the next step. And readiness for change goes up and down over time. And so when it's a new diagnosis, people are more ready to make a change. When they get a lab result that's not very good, they're more likely to make a change. But after after a new diagnosis and they're on a medication for a few months and things settle down, they go through a period where they're not really ready. And that waxing and waning of readiness for change makes it very difficult for the primary care doctor to, you feel like you're wasting your breath, because I'm talking to every patient with type 2 diabetes about this, but very few are taking me up on it. And that's where lifestyle medicine's got a bad rap, because there are physicians and specialists who will tell you it doesn't work, right? People don't want to do this. And the answer is no, people are not ready to do this at all times. But when they are ready to do this, we need to envelope them and support them. And so that's where what we try to do is we try to get a person who signs up on our website. First of all, they can get into the first week content right away, right? So that they actually get something right so 11:30 at night on a Friday night, and they're online, they can actually get into our initial videos and start the work themselves that day. We try to get them into a consultation with our physicians within 4 to 5 weeks, so that and then we've got the onboarding very paced out. So each week, that from the time that they sign up to the time they see start their groups, they're actually getting a little bit more information along the way. Because we look at readiness for change as this little spark, whatever it was that sparked them to think that they can make the change now, let's nurture that spark, and let's turn that spark into a flame, and turn that flame into a fire. And that's kind of again, kind of this role that we play as the practitioners. Our job is to not extinguish that flame or that spark. And so we're very careful as we work with people to help them realize that, kind of what's unique about them, where their challenges might come from, because we can see that with their our understanding of their physiology, but also kind of nurture them along the way.
I'm just going to take you up on one of the things you've said, because you said you try to find out what is the one thing that this patient can do right now.
Yeah.
So do you have any ideas, like what is a common first action that your patients might choose?
Well, so we actually kind of, our first 4 weeks of our 12-week program, we call them the foundations. And so the very first thing that we actually do, kind of first week, is help people understand just how much glucose is coming into their bloodstream when they eat certain foods, right? And so it's really kind of a way of understanding, the concept of glycemic index or glycemic load. And we build it on this, we build it on this little factoid that I still find remarkable, which is, at a normal blood sugar, there's only a single teaspoon of glucose circulating in your blood. So, imagine, taking that teaspoon and putting it into 4 or 5 liters of fluid. That's how much sugar, is in your bloodstream at a normal blood sugar. So it's no wonder if you drink a 32-ounce Coke, that you're going to consume 10 to 12 times the amount of glucose that's currently in your blood, and it's going to get absorbed very quickly. We break that down a little bit further, though, and how allow people to see that many of the refined carbohydrates that they're having, or even things like white rice, are also going to be challenging for them. And so there's a lot of glucose coming in, and so we teach something as simple as that and help people kind of understand that concept, and then help people understand what foods are going to have, lower glycemic index, lower glycemic load, what foods are going to have higher glycemic index and higher glycemic load. So that's week 1. Week 2, we help people understand why ultra-processed foods are going to be challenging for them, and essentially, we simplify it down to, ultra-processed foods, by the nature of their absorption and the way they're designed, they simply do not generate the satiation signal proportional to the calories that are there, and they lead to energy overload, which is the underlying cause of insulin resistance. So we simplify that down, and then again we give them, we have an exercise called ditch from the kitchen, kind of things that you would find in your kitchen that you should probably get rid of. And then we have another kind of parallel one called, switch in the kitchen, things that you can bring into your kitchen that you probably should have around, and it'll help. The third week, we talk around the role of fasting, and not these huge, long, crazy hit fasts, but 12 hours, right? And we teach people that the natural circadian rhythm, the light-dark cycle, the 24-hour cycle of light and dark, has a profound impact on your body. 30 to 40% of your genes turn on or turn off on the basis of the circadian pattern, right? And so if you look at what our default, glucose is our default fuel in the day, fat is our default fuel at nighttime. If we want to get rid of insulin resistance, we need to lose fat from our liver primarily, but we need to lose fat overall. If we're going to lose fat, we have to be able to burn fat. We've got this natural period of time with our physiology where our body's aligned to burn fat. The problem is, if you eat right to the time you go to bed and you eat right when you get up, you may not even have enough time to flip that metabolic switch and get into any fat burning, or you're only spending such a small portion of time in that fat burning zone. So we teach people that a 12-hour fasting period is going to help. It also helps from the standpoint of nighttime snacking tends not to be the most the best calories. And then the fourth week, kind of in this foundations, is just the role of 150 minutes of exercise. Just trying to get people up and moving for at least 150 minutes a week. And again, we kind of, so the course is really laid out at these foundational levels, these foundational behaviors. We spend a lot of time helping people understand it. And then the practitioner will kind of cherry pick, right? Because I see people before the 4 weeks, and I know that they're going to get the nutritional content. I'll often plant the seed, if they're not doing anything for exercise, I'll talk to them about exercise in week 1, and I'll say, hey, let's get a jump on this 150 minutes. But some other people they're doing the exercise and it's something else. Sometimes it's alcohol. We notice that, okay, you know what, the alcohol you're drinking is probably not helping you here. How can you reduce it? And you just help people to start to realize some of these things that are perhaps a bit more unique to them.
Yeah, well, you've covered a huge amount of ground there, and we haven't even spoken about sleep and stress, which I know is another thing. But you've mentioned insulin resistance a lot, and I know that in your program, you do a kind of a workup with various tests to see where people stand on the insulin resistance spectrum and so on. So can you just let us know a little bit about the tests that you order and how you check for insulin resistance? Because my impression is that we've got this sort of kernel. Well, it's a very big kernel because it's an epidemic now. It's one of the plagues of our time, type 2 diabetes mellitus. But we've got people with established diabetes, and then probably a bigger group is what we, for want of a better word, we call pre-diabetes. It might not be the best word, but we can call it, they're almost there. But then probably there's even a bigger group outside of that. They're not showing evidence of diabetes or pre-diabetes yet, but they've got insulin resistance and they're at risk for all these things. So is it possible to identify that group at an early stage where hopefully we don't even have to wait for people to develop type 2 diabetes and then try and get them into remission? If we can hit it off at a really early stage, isn't that good preventive medicine?
Absolutely. And it's, if we go back to the diagnosis of type 2 diabetes every 3 minutes, the analogy I use is we've got a car driving off a cliff every 3 minutes, and we put the ambulance at the bottom of the cliff, right? Once the problem's fully manifested. Really what we need to do is climb the cliff and put a barrier there. And that barrier would be to prevent somebody going from, who has some degree of insulin resistance from developing type 2 diabetes. But let's back up for a second. If we look at the definition of, what's happening with diabetes, so obviously it's an issue where your blood sugars go up. But really it's a challenge that you don't have enough insulin, right? And that happens for two reasons, right? So one is your pancreas could be reduced in function and you might not be able to produce a lot of insulin. But more commonly, what we see in type 2 diabetes is you're producing the insulin, but there's resistance to that insulin. The insulin's not working properly. Why doesn't the insulin not work properly? Well, the primary reason for the insulin not working properly is fat in the cells of the insulin-sensitive organs prevents insulin from working properly. And so you kind of back up from there. So, it's fat within the cells of the liver, fat within the cells of the muscle, but also within adipose tissue. The adipose tissue gets disrupted, and the pancreas itself gets disrupted by this ectopic fat or fat kind of in the places it shouldn't be. When you look at a person, you can actually tell if this is going on. For some people, not everybody, but for many people, you can tell by simply measuring a waist circumference. Our waist circumference is perhaps kind of our best tool to start to identify that you're starting to accumulate fat in places it shouldn't be. So you're getting belly fat or visceral fat. That correlates very well with fat in those tissues that I talked about that's causing the insulin resistance. So we actually can start to identify it right away from that perspective. When we look at, and then you start to back up and it's like, well, why do we get fat in the wrong places? Well, each of us has an ability to store a certain amount of fat in our healthy zones. So our healthy zones for fat are kind of our legs, hips, butt, kind of that gluteofemoral zone. And but that ability to store fat is largely set by about age 18, right? And so our number of healthy fat cells is set by age 18. If we continue to gain weight beyond the capacity of those fat cells to store, those fat cells start to leak, and that's why you get this fat kind of overflowing into places it shouldn't be. And this concept of personal fat threshold is very, very important because we'll see people who are, we'll see people often that are quite overweight, but metabolically healthy on all of our tests. And we'll see some people who are slightly overweight, but have full-blown type 2 diabetes and high insulin resistance. And we'll occasionally see people who are at normal weight or optimal weight, but still have insulin resistance. And so it depends on your ability to store fat. At the extremes, we as clinicians, we see people with lipodystrophy who can't store any peripheral fat. They develop diabetes right away. They have a very tiny personal fat threshold. But helping people understand this personal fat threshold, I think, is one of the gifts that we have as practitioners, because we stop demonizing fat and weight, and we start, and really start to explain it from the perspective of, each person can carry a certain amount of fat and be healthy. In fact, you're a paleontologist, you go to other disciplines. I step back and look at evolution and say to people, look, human beings can carry 20 to 40% body fat and be healthy. Chimpanzees carry 7% body fat. So our our strategy to hold body fat is part of our evolution, right? Like it's nothing to be, we shouldn't be worried about the fact that we can carry this fat. It's when we cross our personal fat threshold that our health is being affected. And that's the time where we actually do need to say, hey, you know what? This is becoming a problem because you're starting to get that belly fat, which means that you're getting fat in the other places. And so
It sounds like you really need to distinguish insulin resistance versus pancreatic failure, because we can't be prescribing the same modifications to diet, etc., unless we know that. That's how it seems to me. So can you just let me know how you identify insulin resistance or its absence? How do you measure that?
So what we do is we do a set of blood work at the very beginning. And one of the tests that we'll order is something called C-peptide. And so C-peptide or cleaved peptide is the portion of the pro-insulin protein that gets broken off to make active insulin. And it's a good marker for how much insulin's around. It's better than measuring the actual insulin because the half-life of insulin is very, very short, and insulin's released in a pulsatile fashion. So if you measure a fasting insulin 3 times in 30 minutes, you might get 3 very different values. C-peptide's a little bit more stable. So we measure C-peptide, and then we measure the fasting glucose. We plug those 2 things into something called the HOMA-IR2, which is a nonlinear equation done through software that will tell you, it'll give you a beta cell percentage, so kind of your percentage beta cell function, and it'll give you an insulin resistance score. It'll tell you kind of how many times more insulin resistance than normal you are. About 75% of type 2 diabetes insulin resistance is the problem. About 25% it's the pancreas that's the problem. In our practice and what we see, it's probably more 90-10, that and part of that is the people that are pancreatic deficient. If they're very pancreatic deficient, often they're on insulin already, and they're really being treated much more like type 1 diabetics. But so in our practice, it's probably more 90-10. And then it's important to understand the degree and potentially why this insulin resistance is developing. And here's what we see that's really fascinating is there's probably kind of 3 different subtypes that fall into this. And there's a whole bunch of work that's been done on subtypes. There's kind of age-related insulin resistance. And really what's probably happening here is your muscles, as you age, I just turned 60 on the weekend. So as we get past 50, it becomes a challenge to hang on to your muscles. You start to lose muscle. And your muscles are the great buffer for carbohydrate. When you eat carbohydrate, 80 to 90% of the glucose in the carbohydrate is going to land in your muscle if your muscles are healthy. As you lose muscle, you lose this buffer. And that becomes a challenge because any carbohydrate that can't get stored in the muscle, you can store a little bit in the liver, but if you can't store it in the liver or the muscle, your liver is going to turn that. It's going to turn that carbohydrate into fat in the liver, and that fat is going to be just prime position to be end up being stored in the liver, causing insulin resistance. So there's an age-related group where people lose muscle, but they also decrease activity. Kind of that goes hand in hand, and they lose this buffer, and so they start to develop insulin resistance, often kind of moderate insulin resistance, and for this population, obviously addressing kind of that extra fat and trying to get rid of that extra fat, but also, trying to get their muscles back in shape is going to be a huge component. There's another group where it's kind of just, it's weight related. It's literally the person that gained a pound or 2 per year from age 18 to age 50 or 60. You hit middle age and you've got this extra weight, you're carrying around the middle, and you essentially crossed your personal fat threshold, sometime probably in your 30s and 40s. The insulin resistance builds up. Your pancreas compensates by producing more and more insulin, but that ironically makes things worse from a weight perspective. And at a certain point, you tip into diabetes. For those people, it's really let's address the energy overload issue. Let's reverse some of that weight loss. That's going to make the difference. Again, moderate insulin resistance. The third group, and the group that I actually feel, I'm not sure how to express this, but I feel this degree of compassion for these people because they're the people with severe insulin resistance. So there's something else going on here, and it's probably genetically driven. They're probably aligned that there's somebody that gets a severe insulin resistance, and then they have this severe response. And I think you've had Dr. Jim Johnson on, and there's an argument whether, does the high level of insulin come first or the resistance come first? And there's a bit of, chicken and egg there. But these people have these super pancreases that produce a ton of insulin. And so as they develop insulin resistance, the pancreas just produces more insulin. And their blood sugars stay normal for a long, long time. And so as physicians, if all we measure is their blood sugar, we're telling these people, oh no, you're heavy, but your blood sugars are fine, until they finally tip over. And when we go and measure their C-peptide and look at their insulin production, they're often producing 400% the amount of insulin compared to normal, like 4 times the amount of insulin. And so the effect of insulin is your body, when normally insulin is released as a signal to food, it's your body's signal that there's food and energy to be stored, right? So it's this massive storage signal. So you think about this, if you're a person walking around with 4 times the level of normal insulin, your body's screaming, store energy. You eat, you store the energy, high levels of insulin inhibit fat burning, you get hungry 2 hours later. And people look at you like you have no willpower, and what's wrong with you that you're eating this much? And when I explain this severe insulin resistance pattern to patients, and they often, in our program, they come in with an A1C, they're often pre-diabetic. Their pancreases are so good, it's not about high blood sugar levels, right? But they're so highly insulin resistant, but as a group, they tend to be heavier, right? Their BMI is often 35 to 45. When you measure this and show them that, look, you're producing 4 times as much insulin as normal, that's sending this massive signal, people often cry. It's the first time they've understood their bodies, right? And so it's this illuminating factor where they realize this severe degree of insulin resistance, that's my challenge. And so and this is what I love about this program is then, the practitioner's job is to help them understand how this strategy that we've outlined, the elements that are going to be particularly effective for them in terms of unlocking their ability to restore fat burning and start to decrease the fat from their liver and reduce that insulin resistance.
It sounds like you really do not want to have a super pancreas. That's a bad thing to have.
It's a trade-off, right? Because on one hand you don't have an A1C of 11, right? And you don't have all the damage that comes from high glucose, but you get all the damage that comes from high insulin. And this is something that I feel we need a paradigm shift in medicine on type 2 diabetes, because we've anchored on glucose and glucose control, because that's what the drugs do, right? And so we've anchored on, it's all about the A1C. Well, for these people, the A1C is actually not that meaningful, right? Because their A1Cs are often quite well controlled on, they're on nothing. They because their pancreas compensates so well. But when we look at, what happens with type 2 diabetes, we've got 2 kind of big groups of complications. There's the microvascular complications that are often related to higher levels of glucose. So, the retinopathy, the neuropathy, and the nephropathy, right? So your eyes, your kidney, and your nerve cells. But on the macrovascular side, where you start to look at cardiovascular disease, that correlates with the insulin and insulin resistance. And so the risk for that happens before the blood sugars become abnormal. And so when you look at kind of the complications, that we're kind of missing the boat for these people on that. What's the number one reason for cause of death for type 2 diabetes? It's cardiovascular disease. And so I feel like, we just have not been thinking about this for type 2 diabetes the right way, right?
So should we as family physicians just be, as a screening test for everybody, especially overweight patients, be doing a HOMA-IR2? So doing a C-peptide and a fasting glucose, crunching those numbers, getting a kind of a coefficient of insulin resistance, and then acting appropriately. I'm talking probably big costs to the system in the short term, but in the long term, probably cost savings if you can identify these people early.
Well, it's like everything we do in medicine. You always ask yourself, well, what will you do with that information?
Yeah.
And will it change what you do? Um, and I think I'm not sure that it changes what you're going to do in primary care, right? As a lifestyle medicine practitioner, it completely changes what I'm going to do within the programming. So I'm not sure from that perspective. There are some other ways that we can start to identify this, right? So, if you wanted to be a purist and you could step back and say, well, do you really need that, Brendan? Could you not do it through a combination of, would it not show up with waist circumference, BMI, triglycerides, liver function tests? Could you not kind of, and we do these other tests as well to get that whole picture for somebody. And so, yeah, I think that if it will change the way that you practice with your type 2 diabetics, then yes, you should order it. For a lot of primary care practitioners, I don't think that will change kind of how you practice per se. And I think that, for one of the benefits of sending a patient to LifestyleRX is just that we actually will use that information to guide us. Now, the one place I would say that it may really change your thinking, though, is when you have somebody that comes into your practice who's thin, doesn't look like they have any of this extra fat, looks like they've actually got pretty good lifestyle behaviors from chatting with them about exercise, nutrition, and sleep and stress, and they're struggling with kind of wildly variable blood sugars, and for them, maybe doing this is going to be helpful. Now, to do it, what you have to do, and this is where things get a bit more complicated, you can't just order a C-peptide and know what's going on, right? You always have to do the C-peptide and the glucose together, and then you can eyeball them and kind of tell what's going on, but not really. You have to plug it into this formula. Now, you can download. There's a little piece of software from Oxford you can download, and that can give you that interpretation. And then the other thing you have to always do is you have to look at the whole picture, because like any blood test that we order, there's sometimes variability, and sometimes one test doesn't make sense in the whole picture. And so you have to always be a little bit more careful with that. But I do think that, it may be helpful in that person that you suspect this is pancreatic deficient patient.
Yeah.
And, what's interesting with those patients in our program is the strategy is, we actually use the same strategy, but their goal is quite different, right? So their goal is not to lose fat to reduce insulin resistance, because often they don't have that. Their goal is very much to maintain better blood sugar control using the same kind of elements of the strategy. And initially when we launched the program, I thought maybe these patients need their own program or don't belong in this program. And what I found with it was that they actually, the strategy is similar. There's different elements that you really emphasize with somebody whose pancreas isn't working well.
Yeah, that's amazing. I'm just interested also, you've spoken about the massive incidence and prevalence of type 2 diabetes. And I'm imagining here how many patients with type 2 diabetes that we're aiming for remission, all the wonderful work you're doing in your clinic, but your total patient load is maybe a few thousand, I'm guessing here. But if we look at British Columbia as a whole and how many adults there are in British Columbia, I mean, they're probably, I'm guessing again, but at least 100,000 people that potentially could benefit from this approach. How do you scale this up so that we get to more people that need this advice?
Yeah. Well, and this was the other piece that kind of came to me when in that first week or two of COVID was that one of the benefits of a virtual clinic is it's accessible to everybody in the province, right? And so we get people from all over. We've had people from Tumbler Ridge, so we see people from all over the province, and so virtual is actually really good for scaling, right? We've been able to launch our clinic in BC, Alberta, Ontario, and the United States in 2 years. If we were building physical clinics, we wouldn't be able to do that.
Yeah.
So what what we essentially do, and we think about LifestyleRX as a clinic, what we're actually doing is helping people with type 2 diabetes who want a lifestyle solution. We're helping them find a practitioner who practices that way. And so we now have over 60 practitioners working with us, most of them part-time. And so one of the things that I would say is right now we get about 800 people per month, so about 10,000 a year in at our current rates in British Columbia. And so I just encourage practitioners that are interested in doing this work to reach out to me, and we can train you and we can get you up and running on the platform, and you can be doing this in short time. And this can be part of how you practice, right?
Right. Well, I certainly hope this is the way of the future and the wave of the future. But as I see it, type 2 diabetes is one of the plagues that's besetting our society. I mean, two of the other obvious ones. There's also chronic disease in general, and you've mentioned that. But there's mental health problems, and there's Alzheimer's disease, dementia. They all increasing, and they all in some degree seem to be related to insulin resistance. At least that plays a part in them. So do you track any benefits that the people that you're counseling, with all the advice that you're giving, does their mental health improve? And just maybe down the road, will we see a decreased incidence and prevalence of Alzheimer's disease? Maybe. Can we measure that?
Yeah, so we're starting to do some work with UBC, Dr. Jonathan Little, and starting to look at our data. We're also doing a project in Fraser Health around looking at kind of costs accrued to the system, and can we start to measure that? But you've kind of hit the nail on the head, where when we look at what causes chronic diseases, and there's this, and if we look at kind of what ails us in our society, it's very much these chronic diseases. They either have kind of at their root insulin resistance or chronic inflammation, or both. And chronic inflammation and insulin resistance are signs of a disrupted physiology. And so what are our biggest inputs to physiology are our behaviors. And so we've got these massive levers of nutrition and exercise and sleep and stress response and social connection. These are massive levers for us that can improve physiology. And so when the root cause of, and we just launched a metabolic health program, for diseases outside of, that are metabolically affected. But there's about 20 different diagnoses that fit into that camp, where insulin resistance, chronic inflammation are either the risk factor or causal for the disease in question. And so we have a lot more control on our physiology than we're giving ourselves credit for. And the hard part for this is it's not as simple as taking a pill, right? It does require these changes in your life and work. But what's really cool, and you touched on it, is we'll see people. So I actually had a patient like this who she came into our program and severe insulin resistance. So she's one of those patients that I was having that conversation about, this insulin storage signal. And I warned her. I said, hey, you know what? This might be challenging for you to get the weight loss started because you've got such a signal there. But we're going to, just work at the behaviors. There's other things that you're going to notice, right? Your food cravings will start to decrease. That's a sign that things are improving. Your energy levels will improve. You'll even improve in terms of mood and anxiety. And she was scoring, because when every patient that comes in, we do a set of questionnaires, we do some screening on mental health. And so we do a PHQ-9 for everybody. And she was scoring severe depression. We also do a G87, severe anxiety. After 12 weeks, she had lost a little bit of weight, not anything dramatic, nothing that that she was ringing a bell for. because she was in that severe insulin resistance category with the super pancreas, her A1C wasn't really the issue. So it was kind of about the same, right? And I think it was like 6.1 or something like this. But she said, I'm a different person. And you look at her severe depression, severe anxiety, both of them improved down into the very low levels on both those scores. But she just described it that she was just a different person. And she hadn't felt this way her whole adult life. And so that was, again, disrupted physiology has effects everywhere, right? And so one of the things that I teach people in terms of as they start to make these changes, pay attention to how you feel. Your body will tell you, and your body will tell you when things are better because you start feeling better, right? And so don't put we don't measure your success by the scale or the A1C tests. Those are markers on the path, right? Those are signposts on the path. But day in, day out, are you feeling better than you were before? That's what should be motivating you, right? And I think that that's the most powerful feedback. But too often we don't connect how we feel to what we've done, right?
I think that's really inspiring, but I'm also going to say it's not totally surprising to hear that. I mean, one hears stories like that a lot, and all I can say is, I suppose one can get similar beneficial effects with antidepressants, but it's really rare. It's unusual to get that degree of someone say, I'm a different person. It's unusual. So,
but here's one of the things that again I love with lifestyle medicine is let's not get caught in a false dichotomy of lifestyle or medicine, right? Like we're physicians, we've got these extra tools. But you know what? Like we don't always need to pull out the power tool when a screwdriver will work, right? And so, the way I look at it is we've got these lifestyle factors that are very powerful. So you look at depression. For moderate depression, so for mild or moderate depression, drugs work, psychotherapy works, exercise works. They all work to about the same extent. But guess what? They're synergistic. Right. And so let's, as practitioners, start to go, okay, we can combine a few things. If I've got somebody in front of me who has moderate depression, and I can, we can, activate the behavior to get them moving. Let's go with that. Let's try some psychotherapy along with that. We can use meds, we've got them, but we don't necessarily have to go for them right away.
Yeah.
The challenge, though, comes back to the exam room. Right. And it comes back to what can we do in the confines of a 10-minute visit? Well, psychotherapy, we might have to refer out to. Well, that's not very easy. And the waiting lists are long, and there's cost involved. Activating somebody's exercise. Well, I need to kind of understand them a little bit more than I can in 10 minutes. So unfortunately, what I can do is I can write the prescription. And so much of our approach to chronic disease, unfortunately, is governed by this constraint that we have. And I think that as practitioners, what we need, and the reason we created LifestyleRX is I wanted to give something that's easy for you in that 10 minutes. Have the conversation with somebody to do you know the role of exercise and nutrition and sleep and stress? Do you know the role of that on your disease? Do you have a good strategy there? Do you need some help? Like simple questions that you can have a chat about in 10 minutes. And here's a place you can go for that. And
the easiest thing to do is to write the prescription. And I know from my own experience, we have good days and bad days. And on a good day, you're on top of your game and you're promoting lifestyle medicine. On a bad day, oh my goodness, here's your prescription. We're all human. Physicians are human too, and sometimes we have a post-lunch dip where we're not feeling very well at 2 o'clock in the afternoon. And I think if someone analyzed my practice, they'd find I wrote more prescriptions at 2 p.m. than at any other time of day.
Yeah.
But you're right. Where to find the time to do these things.
And it's not that the prescriptions are wrong, because they are useful tools, but we should have more in our toolkit, right? And so that from what I wanted to, so I had a patient in when I was working in one of the clinics while I was doing my EMR work. I had a patient I was filling in, so I was filling in, and as saw this patient, and she was in her late 50s. and she was on 12 different medications, and she was there for a refill. And I asked her kind of around nutrition kind of questions, and she's like, well, I went to the diabetes education center, but it didn't make sense to me, and it was only a day, and so that it didn't change anything. Okay, how about exercise? My knee, my knee prevents me from exercising. And okay, how's your sleep? Oh, my sleep's terrible. I have sleep apnea, but the CPAP doesn't work, right? And in the 10 minutes, honestly, the only thing I could do that was useful for her was refill the prescriptions, because it was kind of like we needed a Formula One team around her, like an exercise physiologist and dietitian. And so that's some of the challenge. And I think that it's the last thing I want to do is blame the primary care provider for any of this, because put it this way, there aren't enough primary care providers. You're running 100%. Time is very precious. And so this full stack virtual care piece that we have with LifestyleRX actually allows the practitioner not to have to spend we don't have a practitioner spending 40 hours with the person, yet the person's getting 40 hours worth of kind of content and delivery. And so there's a way I think there's a way to do this. And we've seen it in other areas, like the CBT skills group that's developed, almost similar, very similar to what we've done with LifestyleRX, out of the same constraints of COVID, right? And so it's one of the things that when we look at innovation, constraints are good for innovation. That's why sometimes things change when there's a challenge or crisis.
Right. Just a couple more questions. One thing which I'm assuming, which we haven't really discussed, but I'm assuming you tell people this is not a cure. This is, if you go back, if you do your 12 weeks with us and you do very well, but then you go back to your old ways, unhealthy metabolic ways, it's probably going to come back. So it is a kind of a lifetime commitment.
It's a lifestyle, right? And so I think what's really important is that you're on a path towards type 2 diabetes, or you're on the type 2 diabetes path. And really what we're trying to do is change direction. And once we find that we're going in the right direction, so once you start to feel better, once you start to see your blood sugars improve, once you start to see the scale go down, you're actually headed in the right direction. That's all we need to do.
Yeah.
Whether you get to remission or not is, it's a little bit arbitrary.
It's
right?
relative. Remission is a relative term.
I don't like remission as a term, and the reason being it's anchored on blood sugar, right? And it's the wrong anchor. In our practice, we don't deprescribe medications at an A1C of 6.4, because we assess how much insulin resistance is there still present, and are the drugs that the person's taking useful towards that insulin resistance or not? Are the drugs useful for any other reason, right? So it's a bit more complex, and I feel like remission, it's inspiring and it's hopeful. True remission in our program is when the insulin resistance is completely gone and there's no need for the medication.
Right. Just a few things I'd like to clarify, for both for physicians and for patients. So I know you're looking for more physicians. If you can just let us know how physicians can approach you if they want to join the program, they want to become part of your LifestyleRX program. So not just referring people, but becoming more a part of it. And then also, just to confirm, my understanding is that for British Columbia patients, this is all covered through MSP, Medical Services Plan. So there isn't a cost to the patient. But if you can just confirm that, please.
Yeah. So I'll take the second one first. 100% publicly funded. So patients do not pay anything to join the program. And so they can join the program. They get access to the online platform. They have access to that forever. Plus we have an online community with about 8,000 people in it now. So they've got access to this community, and they have access to the online material and access to the physicians, all covered through their MSP fees. The second is, if a practitioner is interested in this, Probably the best thing to do is if you go to our website, lifestyrx.ca, there's a providers tab. It talks a little bit around some of the science of this. It talks a little bit around kind of the philosophy. And then there's just, there's a little thing where you can connect with us and you can say, hey, I'm interested in this. And then one of our team and myself will reach out and chat. And we've got a physician training course. So we can train you on the material. We have physicians that you can shadow with, so you can actually join in the Zoom sessions to kind of understand kind of what a consultation looks like. And you can join in on some of the groups and see how this all works. And so what we love about having more physicians joining us is we also see this as creating a ripple, because when you start practicing this way, I think it really helps you kind of understand kind of back in primary care, just like all the observations, Charles, that you've had, where it's like, wow, this is actually probably more impactful for a lot more things than just type 2 diabetes. And so I think it creates a ripple that way.
Yeah, and another one of our guests, Dr. David Unwin, he calls it happy medicine. As a family doc, it's very fulfilling and rewarding medicine to be practicing this way. But I've just got a final question for you, Brendan. Just if there are any takeaways that you have, because I think there are really relevant takeaways here for patients and for healthcare practitioners, but also for those just involved in the health field in general, because as I see it, I mean, there have to be, I'm not sure if you documented it, but there have to be cost savings to the system, investing short-term, doing the hard work, but there have to be cost savings to the whole system in the long term. And we all know what stress and strain our healthcare system is under.
Yeah. Yeah. So William Hall, who's a health economist, has been working with us and has created a kind of a rough and ready calculator for us, just in terms of systems cost savings. And so right now, kind of, if we look kind of at the results that we've achieved, and so looking at reduced A1Cs kind of across our population, based on some study, and it was an American study, so you have to kind of, the costs are probably different, but it's something we want to get to. But the patients that have gone through already, there's probably a lifetime savings of $80 million in the system, right? And so, kind of annual cost savings right now, and we're tracking around 3.6 million, right? So, so when you look at this is absolutely cost saving, because if the car does not drive off the cliff and crash at the bottom, it's a little bit easier to slow it down and change direction at the top of the cliff, right? So yeah, and this is an area that we're really kind of fascinated to understand better, and we've got kind of all the data in our platform, and and we think it's probably where we should be investing.
Yep. Well, that's incredibly inspiring, Brendan. I just want to thank you for giving us your time today. It's been really fascinating listening to your insights, learning about your achievements and your program. All I can do is wish you well, hope that your program, LifestyleRX, goes from strength to strength. And maybe we can host you sometime again on this podcast if you're willing.
Absolutely.
Greatly appreciated. Thank you. And I want to thank our producer, Ann Mullins, as well, and our technical guru, Graham Wheeler. And of course, thanks to IPTN for sponsoring this podcast. IPTN also sponsors two websites. One is diabetesremission.ca and one is reversingprediabetes.ca. I've visited both of those sites. They're incredible and lots of practical tips, and we'll put them on your screen. Once again, I am Dr. Charles Helm. You've been listening to At the Helm, and I've been interviewing Dr. Brendan Byrne. I really hope you've enjoyed today's podcast, learning about LifestyleRX, and I hope I can look forward to seeing you all again soon. Thank you.
Thanks.